بسم الله الرحمن الرحيم. معاكم دكتور أحمد فؤاد مدرس طب الأطفال. إن شاء الله النهارده المحاضرة بتاعتنا عن موضوع مهم قوي اللي هو الدايريا disease in children. This lecture is adapted from other presentation from my colleagues and professor دكتور أمل محفوظ, دكتور ميسة عامل and the late professor دكتور أحمد عبد السلام مدكور. We define diarrhea as an increase either في fluidity, volume or the number of stool relative to the usual habit of each child. And diarrhea can be also defined as the passage of 3 or more loose stool in 24-hour period. Loose stool is usually the stool that takes the shape of the container. Diarrhea is very important disease and a leading cause of morbidity, mortality and malnutrition, especially in younger infants and children, and it may be causing about 98% of deaths in the developing world. In Egypt, it's estimated that 30 million per year cases of diarrhea occur every year, and more than a quarter of them occur in infant and breastfed children and cause them mortality. Diarrhea can be classified according to the cause into acute watery diarrhea, which include a subtype which is called dysentery, which include the passage of visible blood in the stool. Second type is called persistent diarrhea. The third type is a chronic diarrhea, and we talk about every one of them later on. We will start our talk about the acute watery diarrhea, which you call it acute gastroenteritis, which is the main topic for this lecture. Acute watery diarrhea is called acute gastroenteritis or infectious diarrhea. It includes the passage of very frequent loose or watery stool without visible blood, and it's about 80% of the cases of diarrhea. The microorganisms responsible for the acute gastroenteritis are usually viruses, including rotavirus, most common type, Norwalk-like viruses, enteric adenovirus, and astroviruses. Protozoa cause about 10% of the cases, including Cryptosporidium, Giardia, and Entamoeba histologica. Bacteria cause 20% of the cases, including Campylobacter jejuni, non-typhoid Salmonella, E. coli, Shigella, Yersinia, and Vibrio cholera. In developing countries, the precipitating microorganisms have some difference when you compare the etiology in developed countries. So in our developing countries, the most important microorganisms are rotavirus, enterotoxigenic E. coli, Shigella, Campylobacter, and the Cryptosporidium, especially in malnourished and immunocompromised children. To understand how the diarrhea occurs, we need to revise some of the intestinal physiology. As you see in this diagram, this is the brush border of the small intestine. The usual physiology is that the enterocytes are able to absorb all the fluids and food ingested during the day. In the same time, the small intestine have active secretion of water and electrolytes and digestive enzymes responsible for dilution and motion and digestion of the food. At the end of each feed, the net result is that the absorption is more than the secretion. That's why the result is there is net absorption, and everyone have 1 to 3 or 4 bowel movement every day, so there is no diarrhea. To understand the pathogenesis of diarrhea, the most important pathogenic mechanism is secretory diarrhea, which is most important in acute gastroenteritis. Here is the toxin released by the infectious agent bind to a specific enteric receptor. This binding causes the enterocyte to actively secrete chloride ion into the intestinal lumen, followed by water, which will cause active secretory diarrhea. As you see in this diagram, Here, the secretion is active and more than usual, while the absorption is normal or a little bit impaired due to the infection. The net result is loss of a lot amount of fluid in the enterocyte lumen due to the active secretion. The other important pathogenic mechanism is osmotic diarrhea, in which there is a damage to the villus brush border of the intestine. This damage impairs the absorptive mechanism of the intestinal enterocytes, causing decrease in the absorptive capacity, leading to osmotic diarrhea. Now we go to the clinical picture of the child with gastroenteritis. The child usually, or the infant, has the passage of very frequent loose or watery stool without visible blood. The onset is acute, and the child usually develop a very rapid onset of diarrhea, sometimes accompanied by abdominal pain, cramps, nausea and vomiting, and sometimes there is fever. And this clinical picture is sudden and acute, and it lasts fewer than 14 days. The improvement occurs gradually, and everything will be normal within 2 weeks. The nausea and vomiting are non-specific. They don't occur in every case, but they indicate infection in the upper intestine or the stomach. The fever suggests that there is an active inflammatory process, but sometimes it occurs due to dehydration or other co-infections. Abdominal pain and tenesmus indicate that there is involvement on the large intestine and rectum. The main purpose of history and physical examination is to differentiate gastroenteritis from other causes of vomiting and diarrhea, which is a differential diagnosis for acute gastroenteritis, and we'll talk about this later. And another very, very important value is to assess the degree of dehydration. The main sequelae of acute gastroenteritis, which make us all very worried about this disease, is that it causes dehydration, which can be fatal in infant and small children or malnourished children. It contributes to malnutrition. It will cause electrolyte and acid-base disturbances. We will move now to a very important part of our lecture, is the assessment of dehydration. Assessment of dehydration is to assess the degree of dehydration based on history and the examination. We can classify the degree of dehydration into no dehydration or no clinically detectable dehydration. In these cases, the child have lost fewer than 5% of the body weight. The other type is some dehydration, which is clinically obvious. The child loses about 5 to 10% of the body weight. In severe dehydration, the child usually loses more than 10% of his body weight. Sometimes this severe dehydration is more severe, causing shock, and in this case there is abnormality in the vital signs like hypotension and marked tachycardia, poor capillary refilling. In this case, the child should be resuscitated by giving rapid bolus of sodium chloride in the form of 10 to 20 ml per kg, and can be repeated according to the degree of dehydration. To assess the dehydration, we can use these 4 parameters. We can, to make it easy for you, we can use it as the word GEMS, G-E-M-S. The G is for general condition. The child can be lethargic or irritable or maybe normal. The eyes can be sunken or normal. The mouth and thirsty. Here we don't depend on history. We should ask the mother to offer the child water, and we watch the child how he responds. If he drinks poorly, or he can drink eagerly because he is very thirsty, or he can drink normally. The last parameter is to examine the skin turgor or skin pinch. It can be classified either returning very slowly or return immediately. Regarding the skin pinch, we sometimes it's tricky to examine, so we'll show you the good technique. This is a good technique. You just take a fold. You don't take the skin out. You just make a pinch between your fingers, and then you release your finger and see how the fold, when the fold will return. If return normal or slowly, if it is visible for less than 2 seconds, it returns very slowly if the fold is still visible for more than 2 seconds. This again, a child with some dehydration. We show sunken eyes. This is a child with shock or severe dehydration with very sunken eyes. To assess the dehydration, we put the signs and history we have done in the previous step, and we classify it according to this table. If we find 2 or more signs in each column, this means that the child falls in this column. For example, if the child is restless or irritable together with thirsty and drink eagerly, he is some dehydration or moderate dehydration. If his eyes is sunken but he is drink poorly or unable to drink, he is severely dehydrated. Sometimes we have another signs that can help us in assessment of dehydration, and these signs may be beneficial in obese children, in children with malnutrition, where you can't rely on the traditional signs. The other signs include decreased level of consciousness, sunken fontanelles, dry mucous membranes, tachypnea, prolonged capillary fill time, sudden weight loss if you have the previous weight of the child, if the child is hypotensive, if the urine output is low, if you find the extremities cold. Again, we have assessed the degree of dehydration. We need to do another step, is to assess the type of dehydration. Dehydration can be classified into 3 types. Isonatremic dehydration. In this type, the losses of water and sodium are proportionate. That's why the plasma sodium is normal, and this is the usual type. The hyponatremic dehydration is a type in which the child loses excess water instead of sodium. That's why the sodium will be diluted in the extracellular fluid, and as a result the cells containing more sodium than extracellular fluid, that means the intracellular fluid contain more sodium. That's why the fluid will be shifted from the extracellular fluid to the intracellular fluid, and this will cause the signs of dehydration to be more obvious and to appear to you as a more severe. The opposite occurs in hypernatremic dehydration, in which the losses of sodium is more than the losses of water. This will cause the sodium to be higher in the extracellular fluid, shifting the fluid from the intracellular fluid to the extracellular fluid. That's why the extracellular fluid will not be too much dehydrated, and that's why the signs will not be obvious. Hyponatremic dehydration occur when the child receives a lot of amount of water or hypotonic solutions that not contain enough sodium. The hyponatremic dehydration occur when the mother corrects the dehydration with a concentrated ORS, or the child loses a lot of water in the insensible water loss from his skin if his surface area is relatively higher than his body, which occur in infants, or due to hot temperature, leading to loss of water more than loss of sodium. This is a comparison between the different types of dehydration, the isotonic, hypertonic, and the hypotonic. And as you see, the isotonic is the most common one, which is losses of sodium equal to the losses of water. Extracellular fluid is okay. Thirst is manifested. Skin turgor appears to you easily during examination. In hypertonic solution, the losses of water is more than sodium. Extracellular fluid is not that dehydrated, that's why it's just 1+. The thirst is very manifest. Skin turgor is not lost, because as we said before, the signs of dehydration are not very apparently visible in this type. The child is usually very irritable, more than his degree of dehydration, and sometimes it's associated with a very dry tongue, which we call woody tongue. The opposite occur in hypotonic dehydration. Acute diarrhea, as we said, is a very important cause of morbidity because it can cause complication, especially in delayed diagnosis and wrong management. Hypernatremia and hyponatremia, both acidotic tetany, both acidotic hypokalemia, when you have a rapid correction of the associated acidosis, electrolyte disturbance may cause seizures, but child can have gastrointestinal complications in the form of paralytic ileus, nutrition complications like poor and malnutrition following the acute diarrhea episode. It can precipitate perirenal failure, and it can precipitate disseminated intravascular coagulation or DIC. The gastrointestinal complications also include temporary lactose intolerance, some malabsorption, and some children can have paralytic ileus. When you have a child with acute gastroenteritis, you usually don't need to do investigations. Sometimes you do stool examination if we have blood diarrhea in order to document the presence of dysentery and document the bacterial invasion of the mucosa. We can do stool culture if we have blood diarrhea, outbreak of hemolytic hemic syndrome, if the child is immune suppressed, or if there is a local community outbreak. Plasma electrolytes, urea and creatinine and glucose should be checked if the child will have intravenous fluid for his management, or if there is features of hypernatremia. Otherwise, you don't know investigation to a simple case of acute gastroenteritis. We move now to another very important part, is the management of acute gastroenteritis. The management in all different types and degree of dehydration will include 3 important parameters, which are the fluid therapy, feeding, and zinc supplementation, plus or minus another or other types of management according to each case. According to the degree of dehydration, we classify the fluid therapy into 3 plans. Plan A, which is done for no signs of dehydration at home. Some dehydration will be managed as Plan B at the oral rehydration center. Severe dehydration will be managed as Plan C at hospital, admitted at hospital. Fluid therapy for all degree of dehydration will include 2 types of fluids. The initial rehydration therapy, which is the replacement of the fluid deficit given according to the degree of dehydration. After we fully correct the dehydration, we give the child another type of fluid therapy. We call it subsequent fluid therapy, which includes the maintenance fluid he needs every day and replacement of the ongoing losses that occur with the diarrhea or the vomiting, because hydration will not stop the diarrhea at once. It will remain for a few days later, and to prevent further dehydration, we give the ongoing losses. We will start talking about the initial fluid therapy in every degree of dehydration. The amount is very different according to the degree. Mild dehydration will need 50 ml per kg. Some dehydration will need about 75 ml per kg, and severe dehydration will need 100 ml per kg. How the fluid are given? They are given orally if the child is showing no signs of dehydration. Can be given orally or by NG tube if the child is having some dehydration, and they are finally given IV if there is severe dehydration or the oral or nasogastric rehydration has failed. Plan E will have home-based fluid at home, either ORS, soup, salted, yogurt-based drink with salt, or usual breast milk. He can be given cereal water, he can be given plain water, fresh fruit juice made in home without the addition of sugar. He can be given also weak herbal tea without the addition of sugars. Plan B, he will be given ORS, oral rehydration solution, at the oral rehydration center. We have 2 types of oral rehydration solution, the usual one and the low sodium type. These are the concentration. We don't need to know just the concentration of sodium, which is low in the hydrosafe or decreased sodium type. the osmolarity is lower in this type, which will help the improvement of diarrhea. Glucose is added in every type of ORS because it will help the absorption of sodium and water, as you see in this slide. The mechanism of action of ORS depend on that there is a receptor here or a special gate in the anterior side border facing the lumen. This gate is capable of absorbing sodium, and this capability is much enhanced when glucose is present. So when you put a ORS containing sodium and glucose, both of them will be absorbed more efficiently together with water, which will cause the fluid to be shifted again to the anterior sides and again to the extracellular fluid. So although the diarrhea is still going, but the child does not have dehydration because many of the fluid in the intestinal lumen is taken back to the circulation. So the idea of ORS is the addition of glucose containing fluid combined with sodium to improve the capability of the intestine to absorb all of them, the sodium and glucose combined with water. The plan B will take ORS. The amount is about 75 mg/kg, as we said before. It's given very slowly by the spoon or dropper every 1 to 2 minutes over 4 to 6 hours. This can be given by cup or cup with spoon or dropper or syringe or by NEG. If the child couldn't tolerate oral, he have more frequent vomiting, you will ask the mother to decrease the rate of the intake, or you can insert an nasogastric tube and give the ORS slowly by infusion to prevent vomiting. After the intake of ORS, you will assess your child after 4 hours. If you find no signs of dehydration, so he can be shifted to plan E and given the food-based home fluids. If no improvement, continue as plan B. If worsening and signs of dehydration shifted to severe dehydration, shift him to the plan C. Plan C include the administration of IV fluids in the hospital. The fluids may include benzol or boroelectrolyte ringer lactate solutions. Children given 100 ml/kg, and the rate should be adjusted according to the age. We give 1/3 of the amount in about half an hour in younger children or 1 hour in older children. Then we give the remaining 2/3 slowly in 2.5 hours in younger infant or in older infant, and up to 5 hours in older infants. The patient with severe dehydration should be assessed hourly. We look for the signs of dehydration and for signs of improvement, and we apply the same principle. If he is improving, shift him to plan B, then to plan C. The other type of fluid, which is the subsequent fluid therapy, again we said it include maintenance fluid, which is the usual fluid intake of the child, and the ongoing doses, which is given to correct the ongoing diarrhea to prevent the recurrence of diarrhea. In children below 1 year, after each loose stool, you give the child at home 50 to 100 ml/kg of fluid, either ORS or the fluid we talked about before. In children older than 1 year, you give him 100 to 200 ml of fluids. Shifting now to the feeding during diarrhea. Feeding during and after diarrhea should be very emphasized, and the mother should be very well educated about the importance of feeding during the diarrhea to prevent the associated malnutrition. In breastfed infant, we advise the mother to continue breastfeeding as usual during and after rehydration. In formula-fed infant, we continue the same type of formula. We don't shift to another formula in most of the children unless we have prolonged diarrhea or we have evidence of lactose intolerance. In these cases, we shift temporarily to a low lactose or lactose-free formula only for 2 weeks. Then the child will be shifted again to his usual formula. Children on mixed diet should continue their usual feeding. We give small frequent feeds. We avoid the fluid that is too sweet or have higher fiber content or laxative effect, or fatty food to prevent the progress of diarrhea. The third important parameter in management of acute gastroenteritis is zinc supplementation. Zinc supplementation is very, very important, and it is recommended by all the health care authorities caring for children. It is given in all types of diarrhea, in all degree of dehydration, in every type of dehydration. The dose is 10 milligram for 14 days in children below 6 months, and 20 milligrams in children over 6 months, again for 14 days. What are the other drugs that can be given in the management of diarrhea according to individual cases? Antibiotics are used only in certain indication. We'll talk about them later. Adsorbent and antimotility and antiemetics are not recommended anymore because they carry more side effects. The adsorbent and antimotility, they prolong the excretion of the infectious agent in the stool. Sometimes they have side effects, and they shift our attention and the mother attention about the hydration and feeding. Antiemetics are not used in every case, is used in special circumstances. Antibiotics are used only for cholera and dysentery, especially by Shigella. Antiparasites are given only in Entamoeba histolytica trophozoites, and sometimes we give a specific antibiotic according to a culture. The antiemetics are not used in every case. They are not routinely used. We can use IV ondansetron in very severe cases, admitted cases, which have persistent dehydration, although the IV fluids are used. Antibiotic for the dysentery, and again to revise with you, dysentery is a type of acute infectious diarrhea that lasts less than 14 days, and it's caused by a bacterial agent. So we see mucus and visible blood in the stool. Dysentery is about 10% of the cases of acute gastroenteritis in Egypt. The most important causes by this order are Shigella, Campylobacter jejuni, Salmonella, and Entamoeba histolytica. Treatment include fluids, correction of dehydration, ongoing losses, feeding, and zinc as usual as in the acute watery diarrhea. Antibiotics, we start with a combination of trimethoprim sulfamethoxazole in every child with dysentery. If no improvement within 2 days, we shift to IV ceftriaxone if we have Shigella, or we can give metronidazole if we suspect amoebiasis according to the lab results. After we did the hydration and the child is doing better, he is going to be discharged home, we should give some health education to the mothers. We ask her to return back to the hospital if the child is become more ill, so he can't be able to drink or breastfeed. He become more sick, he develops a fever, he get blood in the stool, he has repeated vomiting, he is very thirsty, and he cannot give him enough fluids. That's why in this case the mother should return urgently to the hospital. Acute gastroenteritis can sometimes be prevented. The available vaccination is targeted according to the rotavirus, which is the most important viral agent and most important agent in every piece of the world to cause acute gastroenteritis in infant and small children. Rotavirus vaccine is obligatory in the vaccination schedule in some countries, but it's not still in Egypt not available as an obligatory vaccine. As we said before, the history and physical examination help us in the assessment of the hydration, and to as well to have the differential diagnosis in cases of acute gastroenteritis. The differential diagnosis will include many of the causes that will cause vomiting and diarrhea, or diarrhea alone. As we see, some infections like urinary tract infection and otitis media may be associated with vomiting and sometimes associated with diarrhea. Surgical causes like the interstitial and the appendicitis and other causes of small intestinal obstruction will be associated with vomiting and abdominal pain. Sometimes the antibiotics and other drugs given by the child for other disease will cause him diarrhea or vomiting. Sometimes the diarrhea is actually an overflow incontinence in children with chronic neglected constipation. Sometimes non-infectious causes like diabetic acidosis or inborn error of metabolism are the causes of the persistent or recurrent vomiting. Other GIT disorder which are not infectious causes like celiac disease, inflammatory bowel disease are the cause of the recurrent or chronic diarrhea. We'll talk now about a special type of diarrhea, which is a persistent diarrhea. Sometimes it's called post-gastroenteritis syndrome. It's about 10% of the cases of diarrhea in children, and the peak age is around 18 months. The persistent diarrhea is actually a special type. It occurs after the infection. So the child starts with the usual acute gastroenteritis, like he is having the usual acute diarrhea with fever and vomiting, and he will improve a little bit, but he will not go again to his usual. Like he starts with about 10 to 20 motions at the start of the disease. Then after a few days, he will have no fever, no vomiting, but the diarrhea is still present, but to a lesser degree. He will have about 5 to 6 motions. They will not cause him dehydration, but he will not never return to his usual activity. And sometimes it complicates dysentery as well. The persistence of this diarrhea will put the child into a risk of marked weight loss and malnutrition and to dehydration in case if he's not having a good intake, or in cases where the diarrhea will increase for another cause. Why in some children the acute gastroenteritis complicate into a persistent diarrhea? We can understand this if we look at this diagram. That the disease starts with an infection causing damage to the mucosa. The damage of the mucosa impairs absorptive capacity, so the child will not absorb the nutrients. He will go into a malnutrition. This malnutrition will prevent him from healing of his mucosa, will impair his defense mechanism against the organism, which leads that this pathogenic factor will continue, so he will not be able to correct his malnutrition, so he can't repair his mucosa, he can't stop the organism, so this all will cause the persistence of the diarrhea. And in these cases, the treatment is not just to correct the dehydration or give antibiotics, or it's just nutritional therapy to improve the malnutrition. In these cases, we can give him a special pre-digested formula to help him absorb the nutrients and to reverse this cycle. So when he had a pre-digested formula, he will absorb it very efficiently. His nutrition status will improve. He will be able to repair his mucosa and to defeat the organism, and with time the diarrhea will stop. The last type of diarrhea is the chronic diarrhea. This diarrhea is recurrent or long-lasting diarrhea more than 14 days, which is not due to a non-infectious etiology. The etiologies can be allergy, like allergy to milk, like cow's milk allergy, or allergy to gluten, which is called the celiac disease. Sometimes the diarrhea is due to chronic autoimmune inflammation, like inflammatory bowel disease, or due to a congenital problem in the digestion or the absorption of nutrients, and the best example is cystic fibrosis. So again to summarize this lecture, the rare diseases are divided into acute gastroenteritis, which is the main etiology, causing about 80% of the cases. It's caused by an organism. It have acute onset, progressive course. The main treatment is correction of the hydration, improvement of feeding, and zinc supplementation. The second type is persistent diarrhea, which starts as an infectious diarrhea and persists because of a risk factor in this child associated with malnutrition and persistence of the infection and with impairment of absorption. And it is treated by giving a special type of formulas to improve the nutritional status. The third type is chronic diarrhea, which is non-infectious due to inflammation, allergy, or congenital abnormality of the small intestine. This is the end of our lecture, and thank you very much.